Hello, my name is Jeff Sparks. I'm a rheumatologist here at Brigham and Women's Hospital in Boston, Massachusetts. I'm privileged to have two of my team members join us to discuss some of their work at the ACR. So I have Dr. Greg McDermott, who's a second year rheumatology fellow here at Brigham and Women's Hospital, and Dr. Vanessa Kronzer, a second year rheumatology fellow at Mayo Clinic. Welcome.
Thanks, Dr. Sparks.
Yes, thanks for having us.
It's an impromptu Team Sparks meeting, if you will. So I actually really wanted to highlight the trainee experience and certainly your work. So I think first, maybe we can just talk about the abstracts that you presented. And I think it comes from a similar data set, the Mass General Brigham Biobank. So maybe Greg, do you want to tell us about the overall data set, and then we can talk about the abstracts after that?
Sure. So the Mass General Brigham Biobank is a clinical biospecimen collection and clinical data collection program that was started around 2010 and has now recruited over 100,000 subjects throughout our healthcare system who have submitted biosamples and have linked electronic health record data in our system. And it's been a great resource for doing studies because many of those patients have available genetic information linked to their clinical records. And it's a really powerful research tool that facilitates kind of asking and answering questions very quickly using their database.
Yep, so out of that huge sample, we've identified every RA patient. I believe it's over 2,000 RA patients that we've been doing many studies with. I'm sure you guys will think of even more options in the future. So Vanessa, you and I, we've actually been working together for several years. I met Vanessa, actually it was virtual, I think, just from an email.
Yeah.
A med student at WashU, and then they were lucky enough to recruit you to Mayo Clinic. But maybe you could talk about some of your prior work and then certainly how that dovetailed into our work together with the MGB Biobank.
Sure. So when I came to Mayo as a resident, I guess 5 years ago, I discovered that Mayo had a biobank called the Mayo Clinic Biobank that had been an untapped resource in rheumatology. And so I took over looking into what data was available and what we could find that might be interesting, starting with rheumatoid arthritis, because it's one of our most common autoimmune diseases. And we started with lung disease because Dr. Madison, who was here at Mayo at the time, had told me that he had a suspicion that the lungs were involved with rheumatoid arthritis. And so my first study looked at allergies as well as asthma and passive smoke exposure and rheumatoid arthritis. And we found significant associations with those, which supported the Dr. Madison's suspicion as well as the rheumatology community suspicion that the lungs and RA are linked. And on the basis of that, I got a grant to work with collaborators in Sweden at the Karolinska Institute studying respiratory disease and RA. And Dr. Sparks has been involved from the very first project there in the Mayo Biobank, and we've subsequently branched out to projects using the Mass General Brigham Biobank as well as your BRASS cohort at Brigham. So a lot of different avenues of answering these questions about lung disease and RA.
Well, great. I'll mention Vanessa is an award-winning, I think the RF awarded her with the Schiff Award for her work with, that we'll talk about here. And she also got a grant from our Verity program, which is a NIAMS funded P30 grant. So maybe you can tell us about the abstract that you presented, I think it was yesterday.
Yeah, so the abstract that we presented here at this year's ACR was about our findings from the Mass General Brigham Biobank on lung disease and RA. In the Sweden study that I mentioned, we had discovered that respiratory groups were associated with increased risk of RA. So chronic lower diseases like asthma again, but then upper acute, upper chronic, lower acute, all these groups were associated, but we didn't study specific respiratory diseases before. So then in the Mass General Brigham Biobank, we wanted to see were specific respiratory diseases also associated with RA besides asthma, which is one that was known. And indeed, we found that specific diseases within those groups were also associated with RA, including sinusitis and pharyngitis, which are novel diseases associated with RA. And in fact, even just linking the upper airway with rheumatoid arthritis is a novel finding as well. I think it extends our mucosal understanding of rheumatoid arthritis and extends it to the upper airway.
Yeah, so tell us about the mucosal paradigm and how this might extend it.
Yeah, so the rheumatology community, has been finding over the last several decades that several exposures related to the mucosa, including periodontitis in the mouth, lower airway diseases like asthma, gut microbiome exposures in the gut mucosa, and even there are some studies suggesting vaginal mucosa might be associated with RA. So those areas had been studied and shown to have associations previously, but the upper airway, including the pharynx and larynx, that had not been studied before.
Great. So there's more opportunity to understand different avenues where RA might start. Now, I mentioned this paper was actually recently accepted in Journal of Rheumatology, which is our first paper out of this data set. So we're really happy about that. So Greg, I'll turn to you. And I'll also mention that Greg was accepted as a T32 fellow on the COMET program and is also part of the OraCore program with Dr. Jeffrey Katz, one of our colleagues. So you work with two Jeffs and some others.
Congrats.
Yeah.
He also did the program for clinical effectiveness this summer at the Harvard School of Public Health. And he's also doing the clinical translational research program through the Harvard Medical School. So he's quite busy as well. But Greg, I think you've got a couple abstracts looking kind of the flip of the question. Vanessa's looking at risk factors for RA. You're really looking at things that happen after RA. So I wonder if you could just tell us about how we've been phenotyping the lung, and then we'll go into the abstracts after that.
Sure. So going back to the Mass General Brigham Biobank, and you mentioned that we'd identified all the RA patients in that data set. We then looked at all the RA patients who had CT chest imaging performed and looked to see if they had evidence of interstitial lung disease, if they had evidence of bronchiectasis or other lung diseases on those scans. In addition, we performed clinical reviews of all those patients to look if they had clinical diagnoses of any lung diseases, and also look for patients who had lung biopsies or autopsies to see if there was any lung pathology that hinted at lung diseases in those patients.
And we had expert radiologists review all these scans to really blinded to what happened in the clinic to understand, sort of a phenotypic picture of whether they have interstitial lung disease as well as bronchiectasis. So huge undertaking. And I think we just started that just over a year ago. So it's great that we have these two products. So maybe you can tell us about the RA-ILD abstract first. This one has gotten a lot of traction on Twitter for sure.
Yeah, so that project was looking at the associations of the MUC5B promoter variant with RA features and timing of RA-ILD. So the MUC5B promoter variant is a relatively common genetic polymorphism, common in some populations, up to more than 10% of European populations, for example. And it has been associated with RA-ILD in previous studies, but no one really had intensely investigated its effect on RA features as well as the timing of RA-ILD within the RA disease course. So those were the questions that we were looking to examine. And we found in our study, so of the RA patients in the biobank who had genetic data, 155 of those had the MUC5B genotype. And those patients had higher odds of not only RA-ILD, but also RA-ILD earlier in their RA disease course within 2 years of RA onset, and also tended to have a bit older age of RA onset. So they had higher odds of RA diagnosis after age 55, which were novel findings that hadn't been reported before.
So it sounds like this genetic factor puts you at risk of having ILD very early in the RA course, but also might make the RA present later as far as older age. Is that their summary?
Yeah, I think that's a fair summary. So it seemed like it was, although the RA-ILD may have been occurring at the same time in those patients, it was early in the disease course, but with often a later onset of RA.
And do you think it makes the RA present later, or do you think that it just represents a different phenotype of RA?
I think that that's a really great question and an area that needs more research. I think that there's a possibility that in patients with the MUC5B promoter variant, there's maybe a different pathogenic mechanism or a different pathway that's contributing to both RA pathogenesis as well as ILD pathogenesis.
Yeah.
But I think that this interplay, as you mentioned already, with the mucous membrane, the mucosal origins hypothesis, and then aging, all of these are really intricately linked to both RA, but also ILD risk. And I think a lot more work, a lot more exciting work needs to be done in that area.
Yeah.
So there's been a lot of interest in airways and rheumatoid arthritis. Vanessa mentioned her study previously that had showed asthma as an RA risk factor. We'd actually looked at COPD as well. The flip side here is bronchiectasis, something that we've known as an RA manifestation for a long time, but we studied that in the MGB Biobank. Can you tell us about that abstract?
Sure, yes. So as you mentioned, I think that bronchiectasis is being increasingly recognized as a significant extra-articular disease manifestation of RA. And the prevalence of bronchiectasis has a really wide range depending on what studies you look at, anywhere less than 1% of RA patients to more than 50%, again, depending on the study and the methods they used and exactly the population that was being investigated. So, and I think one of the big challenges with bronchiectasis is that it comes in different flavors and kind of a spectrum of disease. It can happen on its own, what we term isolated bronchiectasis, or it can occur in the context of other lung diseases, such as interstitial lung disease, where the parenchymal lung disease really pulls the airways apart and leads to that bronchiectasis. And what we wanted to investigate was whether or not that isolated bronchiectasis may be a distinct entity, and what are risk factors for isolated bronchiectasis occurring in patients with rheumatoid arthritis. So in order to investigate that, we did a case control study, and we looked at cases with RA and bronchiectasis without any evidence of interstitial lung disease on that expert radiology reviewed scan that you mentioned, and compared those to controls who had RA, but no RA-related lung diseases, so no bronchiectasis and no interstitial lung disease. And we found that the cases with, in this case control study, RA bronchiectasis was associated with seropositivity, and higher titer autoantibodies conferred a higher odds. We also saw that it was associated with older age of RA onset, longer RA duration, and also lower BMI at RA diagnosis, which was kind of an unexpected finding.
It's interesting. All those risk factors you were mentioning, dovetailing off that, are risk factors for RA-ILD, with the exception of the obesity versus low weight. Dr. Sparks and I had done a study on RA-ILD risk factors recently, and obesity was a risk factor there, which is why I remember going through your abstract and we talked about how it was surprising finding that the low weight was a risk factor for bronchiectasis.
Right. Yeah, I think it's again a really thought-provoking finding, and it makes me wonder whether or not in thin people or people of normal BMI, is the lung an especially important site for them for development of autoantibodies or generating a pro-inflammatory state that contributes to lung disease and RA. Again, we need more investigation in those areas, but you're totally right that it's in contrast to what is seen with obesity as a risk factor for RA and RA-ILD in general.
It really highlights that they probably are distinct entities. The other interesting thing that we found was not associated is there was absolutely no association of smoking with bronchiectasis, which was
that is fascinating,
surprising. So, and we actually looked at MUC5B as well, and there was no association. So it really is probably a very different entity. All right. Well, I'm glad we could give you guys a platform to talk about your abstracts. You usually get to, stand by your poster and interact with people, which could be a good or a bad thing.
Yeah.
But actually, both of you are the same stage and have, during your fellowship, ACR has been virtual the entire time. So I just wonder if you could give your impression about the virtual experience and what you're looking forward to next year in Philadelphia. Maybe Vanessa, you want to go?
Sure, I can go first. So I did have the privilege of going to an in-person ACR as a resident, and that obviously was a fantastic experience. And everybody's been talking about how they missed that. That being said, I'm not used to it like everybody else is. And I will say, I think there are a lot of positives with the virtual as well that maybe have been less stated. But I think the fact, for example, I've been watching videos at 1.25 or 1.5 speed retroactively, and I can see quite a bit more in the same amount of time, which is really fun. And also the fact that it's on demand, like you can watch from home, you can wear pajamas. I haven't actually worn pajamas, but yoga pants. And yeah, there's a lot of opportunities. You can go mow the lawn in between sessions to wake yourself up a little bit. And I think there are a lot of positives too.
You can listen to me on 1.5 speed too, Vanessa. Try to speed it up. I understand how you roll now. How about you, Greg? What are you looking forward to next year?
So I'd agree with Vanessa, actually. I actually also had a chance to attend before fellowship to the in-person one in Atlanta. And I think that there's pluses and minuses to the virtual format. On the one hand, speaking as a trainee or early stage person, that one that I went to in person, I was very fortunate to present an oral presentation there, but it was on, I think, the 4th day. And I felt like I was very nervous and kind of anticipating that the whole time. And it wasn't until I was done with that I was able to kind of really focus on the other, attending other talks and seeing other posters and really fully focused on that. Whereas with the virtual format, you can kind of record and get everything presented and then I think focus on the conference as it's happening, which is nice. And then I agree that it's the on-demand access, the ability to watch things after is really nice as well. But I definitely, I think, miss or can see the advantages of the networking and the in-person aspects. And I look forward to hopefully being back in person and seeing everybody together next year.
Well, hopefully we'll have the best part of both experiences next year. And that's a good point about, recording your talk. It's a little bit annoying to do it so much earlier, but it's kind of nice just to have it done when it's done. Because I remember working on my presentations during planes, maybe sometimes even started them on a plane. But yeah, I'm looking forward to definitely celebrating together. You guys have had an amazing ACR and fellowship so far. It's been my privilege to work with you. This isn't the end. You're still going to work with me, I hope.
Yeah, it's been a privilege to work with you, Team Sparks.
Oh, thank you.
Yeah, thanks, Jeff.
You're welcome. All right, thanks for your attention. We'll look forward to our next video and to the next ACR.